Hello, my name is Ian McCall, and this is a video of the tutorial in dermatology number 3. Now, I've said here that this was directed at first and second year registrars, but really I think it's a bit much. I think it's really for third or fourth year registrars. We're going to have a look here at the DD of papules. Now, papular eruptions, there are many of them, and it's very difficult to subdivide them into any sort of system of diagnosis that's all-encompassing. So generally what happens is that we've got to subdivide them into eyelid papules, acral papules, oral papules, and yellow papules. So we'll go over some of these, more than once in fact. And we'll also have a look at these disorders and ask a few questions on them. Lymphomatoid papulosis, sarcoid, pseudoxanthoma elasticum, lipoid proteinosis, and lichen amyloid. So let's start off. The diagnosis of papular diseases. We've said put them in certain sites, think about papules with certain colors, and also papules with a certain pattern of distribution. So the main sites where you need to know some differentials for papules would be papules in the eyelids, papules in the mouth or on the lips, acral papules, hands and feet, and follicular papules. What about colors? Certainly yellow papules. I mean, yellow papules we will commonly see as eruptive xanthomas, particularly in your undiagnosed diabetics who's got very high triglyceride levels, and they get these eruptive yellow xanthomas on their buttocks. And you'll see yellow papules in the eyelids with xanthelasma. You'll see some yellow papules in the face with sebaceous hyperplasia and sometimes some sebaceous adenomas. And occasionally you'll see yellow papules in sun-exposed areas in really quite a rare condition called colloid milium. I think we'll come to that a little bit later on. Blue-black papules, oh God, there's lots of those. I don't know if it really helps me to go into those. Skin-colored ones, there's lots of those as well. Often it's very difficult to diagnose skin-colored papules, and again, usually go by the distribution. What about these patterns that we were talking about? Papules in the linear distribution, papules in the ciscinate distribution. Sometimes you look at them as single, multiple, and symmetrical. And then you can also look at papules in relation to those associated with bullae, with scaling, and non-scaling. Now, we're going to come across, I'm not going to go into all of these just now, because we'll be coming across these in subsequent tutorials. We're only going to look at some of them in this particular tutorial. First of all, oral papules. There's the condition oral florid papillomatosis. Now, that's usually a papillomavirus, and some of them can be premalignant in the inside of the mouth. I think I'll come back to that in a second. Dyer's disease, and autosomal dominant disorders with scaly papules, greasy papules in grease areas, anterior chest, behind the ears, acrally. As well, but they get papules in the mouth as well. Tuberous sclerosis, must admit, I've got that on my list here, but I tend to think of this as a child being born with connective tissue nevus, a shagreen patch, and some white ash leaf, what they call ash leaf macules, but areas that look like vitiligo. And a kid may only have those two, and may subsequently get a bit of epilepsy. And later on, around puberty, may start to get the angiofibromas on the face, along the nasolabial creases, which help to make that diagnosis of tuberous sclerosis. But have a double check. I've got it listed there as having oral papules as well. Cowdens, we'll certainly come to that. It can give oral papules, particularly on the gingiva. Acanthosis nigricans. Well, the malignant type of acanthosis nigricans can give you this verrucous-like lesions on the lips. Sometimes we think of acanthosis nigricans, it's that black velvety papules that you get under the armpits and in the groin and sometimes at the back of the neck. particularly associated with malignancy, but also with hyperinsulinemia. And so you see it in polycystic ovaries, and there are a variety of congenital syndromes where there's hyperinsulinism as well that have acanthosis nigricans. In fact, I think actually we come to that in a minute or two, so I won't go into it in too much detail. Multicentric reticulohistiocytosis, again, I tend to think that mainly as acral papules rather than oral papules. Lipoid proteinosis does give oral papules, but if you're going to think about lipoid proteinosis, the papules that you're really going to be looking for are along the eyelid margins. And of course, it's usually in a young child that's got hostis and atrophic scars as well. Golt syndrome. Rare, isn't it? Rare. Usually only seen in females. Linear distribution of papules usually on the limbs. And, fat, there's a defect in the dermis, and fat comes right up to the dermoepidermal junction. Hex disease, that's papillomavirus in the inside of the mouth. One of the oncogenic types. But oral papules, let's have a quick glance at this. What have we got? This was florid oral papillomatosis in e-medicine. Don't think we've got any pictures to actually show you in this. But again, this is a papillomavirus, and it's best defined as a type of verrucous carcinoma. So it's similar to the epithelioma caniculatum that you're going to get on the soles of the feet, and sometimes the other verrucous carcinoma that you can get on the genital skin as well. But florid oral papillomatosis can occur. You really need to see some pictures of this. They're saying it also can occur in the larynx, the pharynx, the esophagus. Papillomavirus, if you really breathe it in, can cause you problems all over. Let's flick back. I've got this PDF here that I was wanting to show you as well. This was a guide to common oral lesions. I think we can show you. There's a whole variety of lesions, obviously, that can occur in the mouth. And this particular little PDF had some nice pictures in there. I'll link it to one of the to the beginning section of this discussion, and you can have a look at some of the other things that can cause lesions inside the mouth. But really, we're not. I really should put that away. We're really talking about papules just now. I digress again. What about eyelid papules? If someone comes in with papules in their eyelid, it's a solitary papule. Remember molluscum, just a solitary giant molluscum on an eyelid. You can miss it. It's so easy to miss it. You're not looking for it. Syringomas are going to be the commonest sort of eyelid papules that you're going to see, and extending down onto the cheek skin as well. These are benign eccrine tumors. But of course, warts you can see there. Nevi you can get on eyelids. Sarcoid you can get on eyelids as well, usually a purple-blue type papule. Actinitis, that used to be thought of as one of the tuberculosis, probably really just a variant of granulomatous rosacea. It can present as eyelid papules. Amyloidosis. If we're thinking of amyloid in eyelids, we usually think of hemorrhage. Because, you remember in primary systemic amyloid from myeloma, the amyloid protein that's produced is made up of the small chain molecules, and they deposit around the blood vessels, weaken them, and of course with pressure the blood vessels leak. So you get this bruising around the eyelids in primary systemic amyloidosis. And what else did we have? Lipoid proteinosis for eyelid papules. I mentioned that before. Young child, hoarse, sometimes some atrophic scars on the face, but the thing to look for is whether they've got eyelid papules. Let's have a quick look at this case, because someone put this in last year to my skin consult, one of the doctors, I think, from overseas. And this was the patient. Obviously, it's not a child. This person has had this condition. Let's look. We talked of oral papules in lipoid proteinosis. Let's look at his oral papules first of all. Okay, there are some there on the surface of the tongue, but it was really his eyelid papules that we wanted to see. Let me just see if we can just close this one down and bring up his eyelid papules. Here we go. Look at them here. These lesions here, these lesions here. Okay, so eyelid papules, particularly just at the limit of the eyelid margin, is a typical feature of lipoid proteinosis. Let's just flick back. What about acral papules? Papules that are mainly seen in the hands and feet. Obviously warts, common things are common. So if you see papules in the back of the hand, they're more likely to be warts than anything else. Acrokeratosis verruciformis. That's probably a form fructus of Daniel's disease with scaly acral papules. Acral papules on the palms of the hands, you certainly need to think of arsenic, arsenical keratoses. Epidermodysplasia verruciformis, that's one of the papillomaviruses, and again one of the some genetic syndromes associated with that, and some oncogenic types of papillomaviruses. I think we'll flick into this. It's a DermNet reference that we've got here. I don't know if we've got any pictures. They're saying here that two types of lesions have been described. A flat wart-like lesion that looks like plain warts, varying color like pink to violet in color, and they may join together to big plaques, and the plaques are often reddish-brown. And then there's the verrucous or keratosis-like lesions, normally in sun-exposed areas. There's another variant, by the way, of epidermodysplasia verruciformis that looks like pityriasis versicolor. You can nip into this reference yourself later on. Have a little look at it if you want to learn more about epidermodysplasia verruciformis. Gottron's papules. They're the sort of violaceous papules that you're going to see on the backs of the hands over the interphalangeal and MP joints in a patient who has dermatomyositis. So as well as having Gottron's papules, they should also have the ragged cuticles and have a good look there with your dermatoscope and look at the nature of the vessels along that posterior fold of the nail. Multicentric reticulohistiocytosis, yeah, we said that was listed in something oral papules, but we certainly think of it more as being large papules and nodules on the extensor surfaces of the fingers. Let's flick into DermNet again and see if they've got anything. Yeah, there we go. They've got a picture there of this condition in the back of the hands. Okay, look at some biggish nodules, some much smaller lesions on the backs of the hands in multicentric reticulohistiocytosis. Sometimes referred to as lipoid dermatoarthrosis, very rare. Mucosal lesions, which mentioned, skin lesions and arthritis. Middle-aged women, the first sign of the disease is arthritis, but a quarter develop skin papules. The remainder, skin and joint things at the same times. Okay, skin lesions may cause destruction of cartilage around the ears and nose, resulting in a disfigured appearance. Obviously not a common condition, but an interesting one to think of for acral papules. There were some other papules here on the front of the elbow. As I say, rare condition. Okay, this was a picture. We should put a bigger version of this. This was someone with lymphomatoid papulosis. You can see that it looks almost like a bit of eczema. You know, there's a bit of necrosis in the center of that. Initially, when this papule came up, it was a purple color, and subsequently a bit of necrosis occurred in the center, and then it disappeared. These tumors are CD30 positive, and some cases of lymphomatoid papulosis will subsequently go on and develop sometimes a B-cell lymphoma. It's a curious condition, though, in that the individual lesions may last 3 to 4 weeks and then just completely resolve, but it can be a marker for underlying problems. Syndromes with acanthosis nigricans. Well, acanthosis nigricans we usually think of in association with insulin hypersensitivity, increased levels of insulin, hyperinsulinemia. And so you'll often see it in patients with metabolic syndrome, you'll see it in patients with polycystic ovary, and in those circumstances we often call it pseudoacanthosis nigricans. The one we're worried about is the malignant acanthosis nigricans, but really that's not common. They're saying in one study only 2 of 12,000 patients with cancer had signs of acanthosis nigricans. So it's not really a great marker of internal malignancy. There are a variety of syndromes associated with acanthosis nigricans, but generally in these syndromes there's a degree of insulin resistance, or sometimes a bit of lipoatrophy as well. That's particularly the case in the Lorentz-Seep syndrome. You know, a lot of Down syndrome cases may have acanthosis nigricans. Sjogren-Larsen, they usually have associated neurological abnormalities. Prader-Willi, I think they're just grossly obese. You need to look up some of the others, they're really quite rare. The thing to know is if you've got a newborn with features of acanthosis nigricans, go looking for some syndrome as being the underlying cause of it. We've said most benign forms will show obesity and insulin resistance, and the malignant forms are much less common. This was a case in Dermatlis, but I'll leave you to look at that yourself. If you want to know more about the Lorentz-Seep syndrome with insulin resistance and a bit of lipoatrophy, then you can read up there. Syndromes of poikiloderma. What's poikiloderma? It's skin that looks grossly sun damaged. Usually there's a mixture of telangiectasia with hyperpigmentation and areas of hypopigmentation as well. We usually think of poikiloderma as being one of the skin manifestations, say, of dermatomyositis, severe dermatomyositis. But there are some syndromes with this, and the one to remember is this one, the Rothman-Thompson syndrome. That's going to occur around 3 months of age. And it's a child that's going to be usually fairly moon-faced, will have some marked facial telangiectasia, and they're generally a bit overweight as well. And they're quite sun-sensitive with Rothman-Thompson as well. It's, bear with me 1 second, I'm just going to stop the recording just while I double check this one. Yeah, Rothman-Thompson, rare autosomal recessive disorder, a poikiloderma, 3 to 6 months of age, usually cheeks, hands, feet, sparing of chest, back, and abdomen, and sensitivity to sunlight. Occasionally they'll get bullying. So again, you got a young child with real sensitivity to sunlight in this thing. The other condition you need to think about is going to be that one, erythropoietic protoporphyria. You know, that's when they get squealing when they're out in the sun, little blisters, particularly over the nose and the forehead, and they're left with scarring in those areas as well. Bloom's is another condition with photosensitivity. It's autosomal recessive as well. Again, butterfly area of the face for this telangiectasia, and they tend to have a degree of dwarfism. And generally, you know, this will develop in the first, these features will develop in the first 2 years of life. But I think Rothman-Thompson is the one where it develops the earliest, the poikiloderma and the sun sensitivity. And then there's these other disorders, Cockayne's, keratosis congenita, and Werner's. But remember, Rothman-Thompson, a little bit about Bloom's, and do read up a little bit about erythropoietic protoporphyria. Remember, measure the red cell protoporphyrin levels in these kids. It's probably the most common of the pediatric porphyrias, this one, erythropoietic protoporphyria. Chronic plaques in a patient with this must have been a case that we used to be able to directly access these at the archives. And if you work your way, if you've got access to the archives of dermatology, then you can still work your way into where this particular case was. This was a patient with acanthosis nigricans, mainly at the back of the neck. Just click here to view this case. Where was she? Must have been one of the ones. We have her in Derm Consult. So I think, does she have polycystic ovaries? She'd had the problem for 2 years, slowly getting worse. Sent to me as an epidermal nevus for lasering. Wondered if it was a form first of epidermolytic hyperkeratosis. Late onset histology didn't support this. And she saw an endocrinologist. Her insulin level was grossly elevated. That's the thing you do in those cases, measure their insulin level, and they're usually highly elevated. Then we talked a little bit there about polycystic ovary syndrome. But anyway, this is a very mild form of acanthosis nigricans. This was the histopathology with papillomatosis, church spiraling of the epidermis. These were just some lesions that she had under her arms as well. So the thing would be to get the weight off her, get her insulin level to drop, and then a lot of these lesions would in fact just disappear. Cowden syndrome. We've mentioned them already from the point of view of oral lesions. They're often peripapules in the pans and so they'll come with acral papules as well, papules at the side of the lips, and tricholemomas on the face. Syndrome associated with internal malignancies, particularly of the breast and thyroid. So we said that if you see a patient with what you think are warts in the face, have a close look at their gums, see if there are any verrucous or wart-like lesions there. Then look also for signs of lipomas, fibromas, lymphangiomas, and angiomas. And any warty lesions in the skin will be tricholemomas. This was the reference in DermNet to Cowden's disease. Close-up of the acral hyperkeratoses. They're not marked. Let's just be talking about these lesions here. You know, they're fairly subtle lesions on there. So facial papules, oral lesions, whitey spots in the gums and palate joined together may create this cobblestoning appearance, and acral keratoses. Palmoplantar ones as well, about 40% of patients with Cowden's. And then these other things, the lipomas, hemangiomas that we talked about there before. Then we've said here type 2 segmental Cowden's is considered a type of epidermal nevus syndrome. So it goes in here to the various gene defects that are involved in Cowden's and help to explain the other tumors that they may get, breast, thyroid, are the ones that you commonly have associated with Cowden's. So I'll have a quick read through that again afterwards as well. Trichoepitheliomas. Trichoepitheliomas you're going to see a lot, but you're probably going to see solitary trichoepitheliomas. they'll usually present on the face, especially the sclerosing one. Now this here was an example of a sclerosing trichoepithelioma. The lesion looks a bit like a morphic basal cell skin cancer, but in point of fact it's a tumor derived from hair follicles, and if you have a look at the pathology, you'll see little buds of blue cells derived from the hair follicles, but with a very thick stromal reaction as well that gives it the picture of an infiltrating BCC, but it's really a desmoplastic trichoepithelioma. Generally we excise these things with 2 to 3 millimeter margins. They don't usually get much bigger than that though. You can get trichoepitheliomas, lots of them, particularly in the nasolabial folds here. And sometimes they'll also be associated with tumors in the scalp called cylindromas. And that syndrome can be inherited as an autosomal dominant, and it's known as the Brooks-Spiegler syndrome, where they've got multiple cylindromas and multiple trichoepitheliomas. So we said here, trichoepithelioma, skin current papule, nasolabial folds and eyelids, eyelids as well, worse at puberty. Trichoepitheliomas are found associated with cylindromas, we've said that. Variable penetration, linear and dermatomal forms of trichoepithelioma may sometimes be seen, as well as a variant which presents as a large hemifacial plaque. Don't think I've ever seen that one before. Amyloid, lichen amyloid. You know, if you look at the amyloidoses, there's a variety of them. There's different proteins in the amyloid molecule depending on how it's formed. You know, you've got your macular amyloidosis with your rippled hyperpigmentation on the upper back, and that's usually the protein derived from keratin, keratin molecule. And you've got the ones that are associated with underlying multiple myeloma, which is usually due to light chain proteins from the myeloma. And they're the ones that are usually associated with deposition of the amyloid around blood vessels and the phenomena of hemorrhages as part of the clinical presentation. But then you've got lichen amyloid. And this was a picture. Well, I really will need to get much bigger images. My apologies for that. But these are papules that are on the lower legs here, particularly over the shins. They're usually quite itchy. They may be slightly keratotic. They may be brownish. They are rubbed and scratched. Initially, you might think they are bits of lichen simplex chronicus. They're often in Asians. So that's the group to really look for it. Papular disorder, particularly the lower limbs, and the pathology, if you look at it, the amyloid's in the lower dermis. And I've said here, this can be compared with lichen myxodermatosis, where the lesions are usually seen on the upper arms and the forearms, and histologically, the pathology is in the upper dermis. The lesions in the lichen amyloid are brown, slightly scaly, discrete papules, join up to form infiltrated plaques, particularly over the shins. They're usually very itchy. The papules of lichen myxodermatosis are waxy, dome-shaped, or flat-top papules, and they can also coalesce into plaques, and linear forms are known. This was another example from Derm Atlas, I think, of lichen amyloid. That's a little glance. Okay, this was the example they had, I think, here. You can see how the papules are brown, slightly scaly, quite discrete, and they, in general, they're usually on the lower limbs. Where was this one? Well, the biopsy was done from his back. I'm not sure. I think it looks more like an arm that they're showing these lesions. So, lichen amyloidosis. And the histopathology, you often need special stains in lichen amyloidosis to show the amyloid. It's usually up here as a pinkish deposition within the papillary dermis. Gee, it's difficult. We're probably talking about this material here, but you'd need to use Congo red to try and show up the amyloid there. Okay, let's just go back. Curl's disease as another papular disorder. Now, this condition you are going to see mainly in diabetics, and often diabetics who are on dialysis. And these keratotic papules are itchy, usually on the lower legs or over the buttocks, hyperkeratotic, up to 1 centimeter in diameter. And they may coalesce to produce polycystic plaques. Spares the palms and soles. We've got we should have a good example of curls. Let me just click on this. It was one case that I had. Here we go. This was an Aboriginal lady. These were lesions on her legs. Let's view this one full size. She was diabetic, she was on dialysis, and she had these itchy papules. Now, they're violaceous, they're slightly keratotic, because this is a form of reactive perforating exclusion of collagen material. And these names, again, they're now comes under just the acquired perforating disorders, and as I say, typically seen in diabetics with renal failure, and they'll present with these things on the legs and on the buttocks. Let me just show you some of the other pictures that she had. These were the ones on her buttocks, I think, or upper thigh. See, they're much bigger here, and you can almost see the material perforating through the surface here. Sometimes you'll get them in linear distribution as well, where the skin's been rubbed and scratched, almost like a Koebnerizing effect. And on the lower legs, they were a little bit more, you know, here. It's almost like a bit of ecthyma in this one, with an eroded keratotic papule here. Keratotic plug made up of neutrophils with eliminated collagen and elastin, which is being expelled through the epidermis. Seen extends the surfaces of the lower extremities. And interestingly, the condition can completely disappear after renal transplantation. Sorry, let's go back to, yeah, take us back. Little question here, are mucosal lesions present in lichen myxodermatosus? I said no, they're absent in lichen myxodermatosus. Lipoid proteinosis, we've done that already. I've shown you those things. Just to reiterate it, often seen at birth, associated with hoarseness in a newborn baby. That's because there's infiltration of this lipoid material, hyaline material, into the vocal cords. This infiltrating the vocal cords, and the lesions affecting the oral mucosae. Tongue is often like wood, so it's a thickened tongue. You know, a large tongue is also seen in cretinism in a child that's born with hypothyroid. And then we said eyelid papules are commonly seen in this condition. I think we showed you that case. No, there were some other cases actually. Let me flick into Global Skin Atlas, because Dr. Namir Sadani, Al-Sadani from Iraq, he's got a clinic where he obviously sees a lot of these. So a quick flick into some of these cases. Pitted acne-like scars on the face. 4-year-old toddler, marked hoarseness of the voice from 1-year-old. Waxy appearance, many whitey cream papules infiltrating the lower lip. Let's just have a look at that lower lip. Look at them here. These, they've matted together here. So lipoid proteinosis will give oral lesions, oral papules. And I think the tongue, we can't really see it all that well here, but it appear to be white infiltrates here on the tongue as well. Other cases that he has, let's look at this one here. Acne-like scars as well. Great portion of which have been placed. Acne-like scars giving the face a shiny, waxy appearance. Also suffered hoarseness and difficulty in moving his woody tongue. So the thickened woody tongue, the pitted scarring, the waxy appearance to the skin in lipoid proteinosis. Sorry, just flick back to where we were. Buschke-Ollendorff syndrome. I think of it as being a syndrome characterized by connective tissue nevi. It's an autosomal dominant, widespread dermal papules and plaques, some asymmetrically in the trunk and limbs. Yeah, osteopoikilosis, curious speckling of the bones. You often need an X-ray to show this, particularly the long bones. Connective tissue nevi are also seen as in tuberous sclerosis, because at least 50% of cases of the condition are new mutations. Every patient with connective tissue nevus should be checked for evidence of tuberous sclerosis. Well, that's true. You know, the shagreen patches and the white ash leaf macules that are typical in the newborn with tuberous sclerosis. So if you see something that looks like a connective tissue nevus, sort of certainly think about that. What skull X-ray features are pathognomonic for lipoid proteinosis? Skull X-ray features? Don't know. What's the answer? Sickle-shaped calcifications form dorsal and lateral to the sella turcica, and skull X-rays are pathognomonic. Okay. Early-stage lipoid proteinosis may produce bullae and pustules which heal with acne-like scars. Well, we've just seen that in Dr. Al-Sudani's pictures. What other condition may this simulate? Well, I would have thought EPP, you know, erythropoietic protoporphyria. They get the scars over the bridge of the nose and the like as well. And remember the marked sun sensitivity. Check the red cell protoporphyrins. Sickle-shaped calcifications found dorsal and lateral to the sella turcica, and skull X-rays are, sorry, what was the third place? No, there were only two questions. Question 3, what two features are common to both tuberous sclerosis and lipoid proteinosis? Both have cerebral calcification and papules on the eyelids. Okay, fair enough. Sarcoid. You'll see sarcoid is a great imitator. It can present in a whole variety of ways in the skin. We think of it often as presenting with papules, sometimes skin-colored, sometimes purplish. We think of it with annular lesions, papular lesions on the face. We think of it looking like granuloma annularis sometimes, acrally. But it can even present sarcoid as an ichthyosis. It can present looking like pityriasis versicolor. So it really is one of the great mimics. And remember, sometimes you'll get a sarcoidal reaction to foreign bodies in the skin, so you've got to watch that it's not just a reaction to a foreign body or some foreign body material. The big thing to check with sarcoidosis is the ACE enzyme level, because if that's markedly elevated, it's certainly much more suggestive that the patient's got true systemic sarcoidosis. Skin involvement of sarcoid is either specific, showing granulomas on histology, or non-specific, mainly reactive. Oh, yeah. There are these other skin lesions that you'll see in sarcoid. You know, erythema nodosum, where that may be part of Löffler syndrome, where they've got acute onset of erythema nodosum, and they've got thickened, enlarged perihilar lymph nodes. Skin lesions appear before the systemic disease in 20% of cases. Simultaneous appearance in 50%, and 30% the skin lesions may occur up to 10 years after the systemic disease. Often when oral steroids are withdrawn, because the big time when you use steroids with sarcoid, because we still don't know the cause of sarcoid, but the time that you use it is when there's significant pulmonary involvement, especially if you're getting interstitial lung disease. then, and it's interfering with gas exchange, then you're liable to use oral steroids. And I've said that papular sarcoid commonly occurs in the face. You can look up these various examples of it and some of these off-central fold cases. I've said here this case here was of annular sarcoidosis on the forehead. Click here to view this case. Let's have a quick look at it. Okay, 40-year-old male butcher, 6-month history, infiltrated but at times scaly eruptions, forearms, legs and forehead, also involving his scalp, causing a mild scarring alopecia. 3-year history of myelofibrosis, hadn't required blood transfusions. I thought he had sarcoid. And then, I thought he was a bit young to have the myelofibrosis. You usually expect that disorder of the bone marrow in an older age group. And then I wondered if he might have had sarcoid of his bone marrow as well. He had a raised calcium level, he had raised ACE levels, enzyme levels as well. He had diffuse infiltrates in his lungs with high lymphadenopathy, and he subsequently went on to systemic steroids. These were the various lesions. This was his forehead lesion, these annular lesions here on his forehead. These were some scaly lesions that he had on his forearm. This was the involvement of his scalp with some scarring alopecia. These were the granulomas in the dermis, fairly naked granulomas, a mixture of histiocytes that are here with only a few lymphocytes, not a lot. So we call these naked granulomas, okay, in sarcoidosis. We got his x-ray. Let me just see if that comes up or not. Not sure where I was storing that. Having a bit of trouble getting it. We might leave that one and come back to it later. Nope. Gone. Okay. So, sarcoidosis. What have we got here? What are the various patterns of sarcoidosis? Where may they be found? And this is, it's interesting in sarcoid that different patterns are found in different areas. For instance, annular patterns, particularly face and forehead, papular in the face, nodular in the trunk, angiolupoid with sarcoid involving the eyelids, chilblain-like, lupus pernio, where you've got sarcoid involved in the ears, particularly the lobules, the nose, particularly the tip and the cheeks. Scar-like sarcoid, where, needless to say, sarcoid can occur in scars. You can get ulcerative sarcoid in the legs, hypopigmented in the trunk. Remember I was saying you can get a variant that looks like tinea versicolor. Erythrodermic sarcoid, you're red all over from sarcoidosis. Ichthyosiform or scaling sarcoid, particularly in the trunk. And alopecia can be a form of scarring alopecia in the scalp because of sarcoidosis. So it's a great mimicker of a lot of other conditions there. What systemic features may be seen with lupus pernio? That's, as I said, that's that acral form of sarcoid, and it's one that's commonly associated with systemic features. 75% of cases have respiratory tract involvement, 40% have granulomas in bones with punched out cysts, generally in the fingers. And eye lesions can occur in about 40% of cases. So they can get an iritis and other eye involvement in sarcoid. So, they may need referral to an eye specialist. So lupus pernio, that chilblain-like presentation of sarcoid, think of the systemic involvement that those patients might have and go looking for it. Do you get sarcoidosis in the mouth? I wouldn't have known. Yes, there may be pinhead-sized papules, particularly on the hard palate, tongue, and buccal mucosa, but they may coalesce to form a plaque. Always look in the mouth. It's often a source of a lot of additional material for you, a lot of additional information. Yellow papules, I've mentioned those at the beginning, and we talked about, the xanthomas, xanthogranulomas, xanthelasmas. We talked about sebaceous hyperplasia. What are the yellow papules? A mnemonic for yellow papules is sexy grannies. S stands for sebaceous, all right. E for elastotic disorders. Yeah, all right. Pseudoxanthoma elasticum. That chicken skin-like lesion on the neck especially, where the elastic fibers are perforating through the epidermis. X for xanthomas, talked about that. I for infiltrates, lipoid proteinosis, lichen amyloid sometimes giving yellow papules, EPP giving yellow papules over the bridge in the nose and the forehead. Colloid milium, that's degenerative material. It's deposited just under the stratum, just under the dermoepidermal junction in sun-exposed areas. And the granny stands for granulomas. Well, normally I just think of what the yellow lesions there are, and it comes out as to what the various things are. These are just some pictures from Derm Atlas here on Pseudoxanthoma elasticum. You can have a look at those. And this was someone who had colloid milium. I must make this bigger. You can see the infiltrated granules here. They're sort of waxy yellow type lesions on the skin here. You can actually take a CO2 laser and laser these off, and they won't scar. I've got some pictures of this guy where we've done that. Question there, what are angioid streaks? From memory, there's something to do with Pseudoxanthoma elasticum. These are breaks in the elastic membrane of the Buch membrane at the back of the eye. 85% of PXE patients will show these. So that's why you've got to get an ophthalmoscope and look at the back of the eyes in patients with suspected Pseudoxanthoma elasticum. These lesions appear earlier than the skin changes and may be the only sign of the disease for years. Angioid streaks are not diagnostic of PXE and may be seen in several other skin diseases, and Paget's disease of the bone and sickle cell disease. Okay. The papules in PXE are yellowish to cream colored, skin is crepe-like, lax, redundant folds, the so-called plucked chicken-like skin, often seen on the neck or inside of the upper arms if you've got a patient with PXE. Now remember that in PXE, one of the big problems is damage to vessels. The elastic fibers of vessels are damaged, and so they can get aneurysms, and they can get hemorrhages and present with stroke. So if you've got a youngish patient with a stroke, go looking at their neck, go look to see if they've got any signs of Pseudoxanthoma elasticum that may explain it. Cowdens again. We've said the tricholemomas are specific cutaneous markers for cowdens. Remember, with thyroid and breast cancers, they've got oral lesions, they've got acral lesions. But the tricholemomas particularly occur on the head and neck. Marked increased carcinoma of breast, thyroid, and colon. Other benign features include acral keratotic papules, oral mucosal papules. This was a patient who had perifollicular fibromas, and perifollicular fibromas. Look, I will enlarge all these images. I don't know why I've got these small ones there. Perifollicular fibromas, they're seen in this autosomal dominant disorder, the Bitt-Herd-Levy syndrome. Now, this is another one that has associated malignancies with it. Individuals with this syndrome and their relatives should have abdominal tomography for renal cancers and ultrasound screening for renal tumors. So it's renal tumors that are associated with the Bitt-Herd-Levy syndrome. And I think they can have trichofolliculomas as well as having perifollicular fibromas as being, Lymphomatoid papulosis, I mentioned a little bit earlier on, occurring in crops. Central area often becomes necrotic, lesions disappear. Lesions are similar to those of pit lichenoides, Ed varioliformis acuta, PLEVA. They have a great tendency to necrosis. and many of the lesions heal spontaneously within anything between 3 and 6 weeks. They often heal with scarring. And remember, a certain proportion of these patients will go on and develop T-cell lymphoma. This guy, so did I see B-cell before that they got? I think it's mainly T-cell lymphomas that they will in fact develop. And this was a guy who had these lesions on his trunk, and histologically at the time they were reported as lymphomatoid papulosis, and some of them would in fact resolve and resolve quite quickly. But he subsequently did develop a T-cell lymphoma. Have we got, I wonder if we can get, oh, there we go. I think we'll get some bigger pictures here on this guy. Look at the variation in the morphology of these lesions. Let's look at this one again. Look at them. They really vary in morphology dramatically. And they're very obvious. You're obviously going to biopsy them. Do an incisional biopsy, by the way, into these rather than just a little punch biopsy. This was a lesion that he had in his forehead. In fact, the very first lesion he presented with, it was biopsied, and it was reported by the pathologist as probably being an insect bite reaction, because there were some eosinophils there, along with a fairly deep infiltrate of lymphocytes. But he subsequently then went on and developed these other things, and later on he developed a T-cell lymphoma, a proper T-cell lymphoma of the skin. Look at this one as well. Curious looking lesions, aren't they? Quite bizarre. There's some other references there you might want to look at. Now, what did he have? We often treat lymphomatoid papulosis, by the way, with PUVA therapy. And he got complete clearance with these. But when the PUVA was stopped, new lesions appeared. And he was treated over several years and gradually developed larger resistant lesions and an aggressive T-cell, large cell lymphoma, lymphadenopathy, splenomegaly. He had ablative chemotherapy, autologous marrow reconstitution, but he subsequently died. So beware of lymphomatoid papulosis. What's the most common associated lymphoma with lymphomatoid papulosis? Here we go. Mycosis fungoides in 40%, CD30 positive T-cell lymphoma. In 30%, Hodgkin's in 25%. The presence of clonal rearrangement in lymphomatoid papulosis lesions is not predictive of the behavior of that lesion or the case in general. So, lastly, what are the skin signs of dermatomyositis? Well, it's one of those classic disorders that really dermatologists can often diagnose much better than anyone else. They'll present initially with that some edema of the eyelids and that violaceous color around the eyes as well. They'll often have some erythema on the elbows and the knees. They'll have photosensitivity. You look at the hands, they'll have erythema in the back of the hands, and will mainly be over the joints, MP and IP joints. They may have Gottron's papules over the joints as well. The area between the joints and the dorsum of the fingers is often clear, and remember that's in contradistinction to lupus, where usually in lupus that area is going to be red and inflamed. And then look at the ragged cuticles that they're going to have and the disruption of the capillary loops that you see in that area. So, periocular violaceous erythema, ragged cuticles, periongal capillary dilatation, violaceous papules in the legs, like lichen planus. All right. And erythema. Erythema in the knees and elbows, photosensitivity. Yes, calcification, particularly in children. But watch for that edema around the eyelids as well. There's a couple of other references that you can go to there. I think they're still valid. And lastly, fingal pulp ulcers and scars. Well, a patient comes in and they've got little hemorrhagic lesions in the tips of the fingers or areas of apparent pulp atrophy, then think of these conditions: Raynaud's disease, especially in association with scleroderma; perniosis, just chilblains; scleroderma, we mentioned there; systemic lupus can present with splinter hemorrhages in the pulp spaces; cryoglobulinemia can present that way with finger pulp ulcers and scars as well, because the cryoglobulins precipitate axially where the temperature is coolest; rheumatoid, subacute bacterial endocarditis, that's the one that you've always got to think of if someone's presenting with fingertip and pulp ulcers and scars. Go listening with a stethoscope, see if you can hear any murmurs, see if they've got a bit of fever, see if they're set up, they've got a valve, an abnormal valve, or had a valve replacement where there may be deposits, or they might have Liebman-Sachs disease. But fingertip pulp ulceration, it's usually of significance. And little pulp infarcts, always look at the patient carefully for some of those underlying disorders that may be responsible for that presentation. Okay, a lot of things we had to go over today, some of them quite detailed. I hope, though, it perhaps put into perspective a lot of other facts that you may have learned about these disorders. Now, a lot of this we're going to come across again in subsequent tutorials. There's going to be a degree of repetition, and that's how it should be in most educational endeavors. You build up on things, you remember little bits of things, and gradually you remember a lot about them. If you've got time, look through some of the other references that are in here, and I hope you enjoyed it. Thanks very much.